And right now I would just like to go ahead and introduce Heidi Brown, and she will take it from here. Thank you, Dr. Brown.
Okay, thank you very much. So I have to tell you all that my research, I do research around promoting awareness about bladder and bowel continence in older adults. And my research is funded by the National Institutes of Health through the Department of Urology at University of Wisconsin. And I also partner with an organization called the Community Academic Aging Research Network, or CARN, which is a partnership between UW's Institute for Clinical and Translational Research and the Wisconsin Institute for Healthy Aging. So those are my disclosures of who supports me in the work that I do. Okay. I'm going to start with a pop quiz, and you don't have to answer because I'm not going to tell you the answers anyway, but at the end of the talk, you will all know the answers to these questions. The first question is this: as a person over the age of 65, your chance of having urinary or bowel leakage is 1 in 2, 1 in 3, or 1 in 4. You don't have to answer. We'll ask again at the end. Okay, now, what do you think is more common? High blood pressure, depression, diabetes, or incontinence? Any guesses? Incontinence. Incontinence is more common than all of those other common medical problems. And risks for incontinence include age, giving birth, smoking and chronic lung disease, obesity, prostate problems, or all of the above? All of the above. And true or false, bladder and bowel control problems only occur after the age of 50? False. Okay. Well, you guys already know all this, so thank you very much. I'm going to cancel my talk now. No, you don't know what the answer is to the first question. That's where I have you hooked. Okay. We're going to talk a little bit today about pelvic floor disorders, which are problems with bladder control, bowel control, and pelvic organ prolapse. And we're also going to touch on tips and tricks to help manage or prevent symptoms. 1 in 3 women will experience a pelvic floor disorder in her lifetime. That's a lot of people. So what is the pelvic floor? 1 in 3 women are going to have a problem with it. What is the pelvic floor? I recently had a patient who came into my office, and after she'd been seeing me for 6 months, she said, "You know, Dr. Brown, the first time I came to see you, I was so nervous. I wore sweatpants and sneakers, and I told my husband, I don't know if I'm going to be able to handle this pelvic floor. I thought it was some sort of a gym." So let me tell you what the pelvic floor is. Everybody has one, men and women, we all have a pelvic floor, and the pelvic floor is actually this bowl of muscles that goes from our pubic bone in the front to our tailbone in the back, and it's a sling of muscles that support our internal organs. And it's not just muscles, but also connective tissue, which is the stuff that connects muscles and ligaments. And so men and women all have a pelvic floor. Everybody has a pelvic floor, and it supports whatever internal organs we have: the bladder, the uterus and vagina, the prostate, the rectum, and the anus. So what are pelvic floor problems, and what might you experience if you have a pelvic floor problem? You could have problems with bladder or bowel control, which could manifest as feeling pelvic pressure or a bulge in the vagina, or urine leakage or incontinence, or maybe not leakage, but just overactive bladder, which is the I gotta go. Or maybe difficulty emptying the bladder, urinary hesitancy. You feel like you can't start your stream and then you can't empty completely. Or problems having a bowel movement, or problems with leakage of gas or stool. So there are a bunch of different things that all fall under the umbrella of pelvic floor problems. And as I showed you on the last slide, all those organs are really close together. So there are some risk factors for pelvic floor disorders, and you already got the question right at the beginning of the quiz, but I want to highlight them. 1 in 3 women develop a pelvic floor disorder, and that risk increases with age, so that by the time we get to age 65, it's 1 in 2 women who have a pelvic floor disorder. And risk factors include pregnancy, childbirth, menopause, but these pelvic floor disorders are not just problems of older women. 1 in 4 younger women in the 20 to 40 age group has a pelvic floor disorder. So this isn't just a problem for older people, this is a problem for everybody. There are also lifestyle factors that can contribute, like being overweight or obese, not exercising regularly, smoking cigarettes, or health conditions like having an injury or surgery in the pelvis, or development of neurologic problems like multiple sclerosis or a stroke or Parkinson's disease, diabetes, and then bowel disorders like constipation, loose stools, irritable bowel syndrome, inflammatory bowel disease. So lots of common problems are associated with pelvic floor disorders. So there are 3 major types of pelvic floor disorders, and if I wanted to make this talk shorter, I could just talk about 1 or 2. But when I do that, then everybody says, well, why didn't you talk about the 3rd? So I have to talk about all 3, and I'm gonna go fast, okay? I'm going to start with bladder control, which is the most common. And I want to start by telling you that if you have problems with bladder control, you're not alone. 18 million women in the US have urinary incontinence. So what does that really mean? 18 million adult women in the US have urinary incontinence. Here's a map of the US. Every red dot is 25,000 women with urinary incontinence. This is a lot of people with urinary incontinence. We should be talking about this. It's not just women either. 40% of men and 60% of women over the age of 65 have problems with bladder or bowel control. And we're going to go into more detail about that recently. This chart is hard to read, but it's taken from a report issued by the Centers for Disease Control this summer. They issued their first ever report about the prevalence of incontinence in older adults to really bring attention to the fact that this is an under-recognized problem that we should be taking care of and we should be paying attention to. I want to stop and talk a little bit about how the bladder works, and I want to point out a few things. Okay, this is a picture. If you were to turn me to the side and cut me in half and remove half of my body and look inside, this is what you would see. The pubic bone is right in the front, and that's that hard bone that you can feel if you touch in your lower abdomen. And your bladder sits right behind your pubic bone. And that's why when you get a full bladder, if somebody presses on your lower abdomen, it doesn't feel good. There's a front wall of the vagina which supports that, the bottom of the bladder, but you can see that the hole that the bladder drains from is a separate opening from the hole that opens at the vagina. At the top of the vagina sits the uterus. That's also called the womb. That's where babies grow and where babies come out of. And when babies come out, they travel from the uterus out of the vaginal canal. So they start here and they come out here. And that's how all of the pelvic floor damage happens for a lot of us. So you know how kids always blame their parents? Well, I'm telling you, you can blame your kids, okay? Now on the back wall of the vagina, there's a support. The back wall of the vagina actually supports the rectum. And so if there's a relaxation of this back wall, it can cause problems with the rectum. The way that the bladder works is that it's a storage pot for the urine that's made by your kidneys. And the bladder connects to a tube called the urethra. And there are muscles and nerves that help control the bladder and the urethra. When you're ready to go to the bathroom, these muscles and nerves signal urine to leave the body through the urethra. So this is looking front on, and you can see here, here's the bladder muscle, and then inside is urine inside the bladder, and then there's a little sphincter down here called the urethral sphincter, and then there's a muscle here, and that's the pelvic floor muscle. So the way that bladder control works is really a coordinated dance. Your kidneys make urine and they bring it down to the bladder through 2 tubes called the ureters. The urine arrives in your bladder, and as the bladder wall stretches, it sends a message to your brain saying, I'm full. Your brain then decides what to do. Do you have to wait? Do you have to go right now, or can you wait until the next commercial? You know, is this I'm full and I got to go right this second, or is this I'm full and I can finish my grocery shopping? In order to urinate, the urethra, that tube that through which urine leaves the bladder, the muscle at the very end of the urethra has to relax, and then the bladder muscle squeezes. And so there's a coordination to allow the bladder to empty normally. So your pelvic floor needs to relax at the same time that your bladder muscle squeezes. That's why if people have told you to practice your Kegel squeezes while you're urinating, I'm here to tell you today you shouldn't do that. Because while you're urinating, your pelvic floor muscles should be relaxed. We'll talk more about that in a few minutes. So what are symptoms of bladder control problems? These are things that we know. You can either have trouble with leaking urine, or you can have difficulty emptying the bladder. Some people have a sudden strong urge right before they lose a large amount of urine, and some people just lose small and large amounts when they cough or strain. Some people don't have urine leakage, but they feel like, my Lord, I just can't ever make my bladder empty. It takes forever, I gotta do the potty dance, and I still can't get it all out. So those can all be symptoms of pelvic floor problems. And there are two major types of urine leakage in women. Stress incontinence is not incontinence when you're stressed out. It's incontinence when there's stress on your belly. So when you cough or sneeze or laugh, there's more pressure in your belly, and that transmits pressure to your bladder. And then if the urethra isn't nice and strong, then that increased pressure pushes a little bit of urine out. There's also urge incontinence or overactive bladder. And that's the, ooh, when I gotta go, I gotta go. That's urgency. And then there's, I gotta go now and I can't get my pants down in time. Or I pull into the garage and I'm already starting to go. Or I put my key in the door and it's already happening. I'm getting my pants down and it's already going. That's urinary urgency with leakage. You can also just have urinary urgency without leakage, where you're noticing that everybody around you seems to be able to hold their bladder twice as long as you can. Then there's also something called frequency, which is when you feel like you've got to go all the time. And then there's getting up lots of times to go overnight, and that's called nocturia. Does anybody here have that problem? Does anybody have to get up more than once overnight to go? Okay. Well, I'll make sure to touch on that, if not during the presentation, at the end, about what to do about that. And then there's also overflow incontinence, which is pretty uncommon in women, but is very common in men, which is where the bladder isn't emptying for some reason. And so because you always have a full bladder, you leak. So it's sort of like if you imagine walking down the hall and you've got one cup that's full and one cup that's half full, you're more likely to spill the full cup. If your bladder is never emptying, you're more likely to leak. And it's not really because of a problem, but rather because you're always walking around with a full cup. That can happen in men because the prostate swells and blocks the bladder from emptying well. And it can happen in women if they've had a surgery to treat urine leakage and that surgery has been too tight and now their bladder doesn't empty well. There's also, the most common one actually, is mixed incontinence, where you have a little bit of both, and you say, well, I don't know, doc, it's just annoying. I get wet. I don't know which kind is worse. And then there's continuous leakage, which could be a sign of something wrong, like where somehow there's a connection between the bladder and the vagina so that urine can leak all the time. Regardless of the type of leakage that you have, incontinence can be treated and even cured, and you might not even have to see a doctor. And so what I'm going to do now is give you 6 pearls for self-management of your bladder symptoms. And we're going to go through each of them on one slide, and they're all highlighted in your handout. But the 6 pearls are these: modify your fluid intake, do pelvic floor muscle exercises, practice the knack, do bladder training, do weight management, and do constipation management. These 6 tips can help you cure your bladder problems without ever ending up in my office. Modifying fluid intake. So every day I have patients tell me, oh yeah, my urine problems are fine. If I don't drink, I'm fine. Well, That's a problem. We need to drink water. Water is important, but we need to drink the right amount. And the right amount sort of depends on your body size and on whether you have other medical conditions. For example, if you have constipation, you need to drink more water to help with that problem. Or if you have a kidney stone, you need to drink more water to help with that problem. But I also have patients in my office who carry around a water bottle and they're drinking all the time, and they say, I run to the bathroom all the time, doc. And I say, okay, well, stop drinking so much. I think we can fix you. So it's drinking the right amount, and the right amount varies, but about 1.8 to 2 liters of water a day is the right amount. You also want to try to avoid bladder irritants like caffeine, tea, coffee, alcohol, artificial sweeteners. I always tell my patients, if it's fun, it's probably bad for your bladder. But that doesn't mean that you have to cut out all of these fun things. Figure out which ones are bad for your bladder. Maybe none of them are. I know for me, if I have coffee and then I have the window seat on an airplane, I'm gonna be in trouble, because when I have coffee, when I gotta go, I gotta go. So I don't drink coffee before I get on an airplane. But that's different for every person. But these are a good place to start to see if maybe if you just cut out your tea and start drinking water instead, your urgency might get completely 100% better. The second pearl for self-management is doing pelvic floor muscle exercises. And these are difficult to teach if I'm not examining you and I can't tell whether or not you're squeezing the right muscles. So I asked my pelvic floor physical therapy colleagues. You know, there are specialists, personal trainers for the pelvic floor. They help teach you how to do Kegels, and not just Kegels, but how to relax and contract, because relaxing is as important as contracting. So I asked them, how do you tell patients to do a Kegel exercise, to do a pelvic floor muscle squeeze if you can't feel? And here are some of the analogies that they use. One of them is, pretend like there's a straw in your vagina, or for men, pretend like there's a straw in your anus, and you're trying to drink water through the straw. It's not just a tightening, but it's a pulling up and in, sucking water through the straw. Or imagine you're sitting on a marble and you're trying to pick it up with your anus or your vagina. I used to work with a male doctor. He would always tell the patients to pretend like they were picking up a marble with their anus. I said, you know, I think women would prefer to say with your vagina. I just, you know. But for men, it really is all the same muscles. It's that sling of muscles that goes from the front to the back. So it doesn't really matter which orifice you imagine is sucking something or drinking or picking up something. The basic idea is that you want to pull in. And when you're doing a Kegel squeeze correctly, nothing else is moving and nobody else can tell you're doing it. So that's how to do a Kegel exercise. What you want to do is focus as much on the contraction as you focus on the relaxation. Relaxation is really important, because if you're always walking around like this and I tell you to flex, you're not going to be able to show me very much. Whereas if you're walking around like this and you flex, you can really show me a good muscle. So you want to practice as much with pelvic floor relaxation as with contraction. And you want to work on gradually increasing your strength, your endurance, and your coordination. And you want to start with 3 sets of contractions, 10 contractions each. Squeeze for 10 seconds, relax for 10 seconds. Start doing them laying down. Once you feel like you've got that under control, do them sitting up, and then do them standing. And when you're ready to graduate, you can practice the knack. The knack is when you stand while you rapidly contract your pelvic floor muscles, and then you cough. And basically what you're doing with that set of exercises is teaching your pelvic floor muscle to contract when you're coughing, so that next time you cough or sneeze, your pelvic floor will automatically contract. You're teaching it just like when people say, you know, can you rub your belly and pat your head at the same time, and you have to practice for a really long time because those two things have never been together in your brain before, but you can practice and learn that coordination. That's the same idea behind the knack. That knack, that tight, rapid contractions of the pelvic floor, also suppresses feelings of urgency, and we're going to talk about that more in a couple minutes. This is where I want to stop and reiterate the point that it's okay to try to stop the flow of urine to make sure that you're squeezing the right muscles, but don't make a regular practice of doing that, because remember that those muscles should be relaxing when you're emptying your bladder. Okay? All right. The fourth tip is bladder training, mind over matter, brain over bladder. Okay, so when you pull in the garage and all of a sudden you have to pee, your bladder does not know you're in the garage. Your bladder doesn't know you're getting your pants down. It's your brain, and your brain knows that you're in the bathroom and it's saying, all right, go ahead, we can go, we can go. So what you need to do is teach your brain, we're not going till I say it's time to go. And you did this before. You did this when you were 3 years old. You got potty trained. You learned how to interrupt this. You can do this again, but it's going to take some effort because now everything is like it's on autopilot. It's doing what it wants to do. When I was a resident, I had the worst keyhole incontinence because I wouldn't empty my bladder all day. I would get home, it would be a 12-hour day. I'd put my key in my front door and I'd immediately start to pee. And I'd be like crossing my legs and stumbling up the stairs. I owned a tiny house and I had only one bathroom on the second floor. And that's why urinary incontinence is associated with falls, because of situations like that where you're in a hurry and you're rushing. So it's really important to actually take control. When your brain starts to send your bladder a message, you can intercept it. What you do is a combination of urge suppression, which is where you relax and you do those pelvic floor muscle exercises, because remember, it's never normal to pick up a marble, right? It's never normal to suck through a straw in your vagina. If you do those exercises, your brain is going to know something's up and it's not the right time to urinate. So you can suppress that urge by doing that. And then the other part of it is distraction. We've all been in the situation where we really have to go to the bathroom, and then our kid falls down, or we spill a big glass of milk, and then we pick it up, and then we go on with the next thing, and then we realize a half hour later, oh my, I really had to go to the bathroom. So there really is a big part of distraction as you're gradually spacing out the time between your voids. You want to void on average every 2 to 3 hours. And of course, that's a rough estimate, because if you're one of those people who's always carrying a water bottle, you might have to urinate every hour because you might be filling your poor bladder. So it all depends. But on average, every 2 to 3 hours is about a normal time to urinate. Okay, weight management. I wish that this was the part where I told you the way to lose weight without dieting or exercise. Unfortunately, I do not have that secret. But what I can tell you is that losing 5 or 10% of your body weight, if you're overweight, will improve your urinary symptoms by up to 70%. So in order to lose weight, you really have to consume fewer calories or burn more calories. And it will make you feel better, and it is the kind of thing that you have to commit to and you have to do gradually over time. Calorie counting techniques are very helpful. If you're somebody who goes on the internet or who has a smartphone, there is a calorie counting app called MyFitnessPal that I use with a lot of my patients. And it's basically the same idea as Weight Watchers, where you count your calories, but you don't need to look up what calories are in anything because this program has it all in there. So if you just type in, or if you scan the barcode, it pulls up how many calories there are. And it's a good way for you to keep track of how many calories you're taking in. And it also helps you regulate. So if you're going to have a cookie with lunch, you realize that then you're not going to have enough calories to have a cookie with dinner. So you might choose just one or the other. The other nice thing about that particular app is that it also gives you more calories in your allowance if you exercise. So if you go for a walk, it'll add calories to how many you get for the day. So the name of that is MyFitnessPal. And there are all sorts of things like that. But the idea is to just think a little bit and be a little bit more accountable for what you're putting into your body and how many calories you're burning. And that can really help your bladder symptoms. And then lastly, constipation management. You know, on the picture, all of these things are really close together. So it kind of makes sense that if your rectum is full, there's not going to be as much space for your bladder, and your bladder is going to leak a little bit more. There are a lot of things that are part of good constipation management. Staying physically active is really important, and that can be hard, especially if you've got a bad hip or a bad knee and it's hard for you to walk. Sometimes you can do walking in water, and sometimes you can just do pedaling in place. There are seated pedals, but keeping physically active helps stimulate the bowels to move forward. The other important thing is to drink plenty of water. As we get older, this is kind of a sick trick. Our brain stops telling us we're thirsty as we get older. So we don't drink enough water and then we get constipated. So you need to remind yourself, even if I don't feel thirsty, my body's thirsty. You need to keep water. I tell my patients, put 1.5 liters of water in your fridge at the beginning of the day. By the end of the day, it should be gone. That's how you can make sure you get enough. You also want to get plenty of fiber to help with constipation, but this you've got to do really gradually, because if you do this too suddenly, you'll feel gassy and bloated and you'll say, oh, that woman was so wrong. So you've got to really do it gradually. There are high fiber foods are things like beans, peas, prunes. Anything that gives you gas probably has a lot of fiber in it. And you know, people tell me all the time, oh, I have a salad every day for lunch, so I get plenty of fiber. Well, a cup of lettuce has 0.5 gram of fiber in it. A cup of beans has 8 grams of fiber in it. So you can really get educated about what is high fiber and what's not high fiber. And then there are all sorts of good fiber supplements on the market, and it doesn't really matter which one you use. Just find one that you can tolerate and just make sure that you increase water with the fiber if you're trying to treat constipation. If you do need to use a laxative, the safest one to use every day is something like Miralax, which is not a stimulant laxative, it's just an osmotic laxative. So if you need to use a daily laxative, that's one that doesn't have addictive potential, and that's a good one to use. If these solutions don't work, then you should talk to your primary care provider. Your primary care provider may refer you to a pelvic floor physical therapist or to a urologist or a urogynecologist. Pelvic floor physical therapy is important because pelvic floor physical therapists are actually people who are trained in the muscles of the pelvic floor and also the viscera, the organs of the pelvis. They can help you with some of your behavior modifications and symptom tracking. They can also help not just with pelvic floor muscle strengthening and relaxing, but also with core muscle strengthening and relaxing. And they can also help you get improved awareness of your bladder, bowels, and pelvic floor muscles. If you go to pelvic floor physical therapy and that's not enough, and you ended up in my office, what might I offer you? I always use the analogy of having a knee injury. If you have a bum knee, you can go to physical therapy and strengthen all the muscles around the knee, or you can wear a knee brace, or you can have a surgery. A knee brace doesn't fix the problem, but it stabilizes things and your symptoms get better. And the analogy with urine leakage would be a pessary, which is a little silicone device that sits inside the vagina and supports the urethra, that tube that brings urine to the outside world. Surgery, just like a knee surgery, you know, you have one knee replacement and then 10 years later you gotta have another, or you get a bad infection and then you gotta have the other knee replaced. So surgery, for some people, surgery sounds like a good answer, but surgery is not without risks. So you wanna try these other things before you move towards surgery. There are 2 surgeries that we offer. One surgery is a sling that sits underneath the urethra. And the idea behind how that works is that the urethra, as we get older and we get pelvic floor relaxation, instead of the urethra sitting and being well supported, it starts to flop in the breeze. Kind of like when you were 20, your urethra was sitting in a driveway, a nice, firm, strong backdrop. So if you try to step on your hose in the driveway, you can stop the water going through the hose because you've got a nice, firm backdrop. But then you have a couple of kids, you go through menopause, all of a sudden your driveway's quicksand. So you can step all you want on that hose, but you're not going to be able to stop that water. So what a sling does, or what a pessary does, or what the muscle strengthening does, is reinforces that driveway under your garden hose. If the problem isn't that you need reinforcement under your garden hose, but rather that your garden hose used to be like this and now is like this, there's also a therapy we can do where we put some bulking in, just like you know how the celebrities get their lips pooched out, we can pooch out your urethra, narrow your garden hose. okay? So we can take a garden hose that looks like that, and we can inject it so it looks like that, and then you don't leak anymore. So what about the other kind of urine leakage? Ooh, I gotta go. The best treatment for that, other than bladder retraining and pelvic floor physical therapy, are medications. And there are a ton of medications on the market for overactive bladder. Does anybody know which of these medications is available over the counter? Anybody know? Yeah? Oxytrol, exactly. Oxytrol, this pink one here, is available over the counter. You know why I don't like that? Which ones do you think are safest for older adults? Not Oxytrol. The two that are safest for older adults are one called Sanctura or Trospium and one called Mirabegron. So the over-the-counter one, which you could just go to Walgreens tomorrow and buy, can have a side effect of dizziness and confusion, and it can make you more likely to fall. Now, if you're 45, that's probably not a big deal, but if you're 75, it can be a really big deal. So there are these medications, most of the medications for the bladder are called anticholinergic medications, and they can cause dry mouth, dry eyes, constipation, dizziness, blurry vision, increase your risk of falls. But there's Sanctura or Trospium doesn't cross the blood-brain barrier, so it should be safer for older adults. And Mirabegron is in a different class altogether and shouldn't cause any of those problems with dizziness or confusion or falls. But that one can increase your blood pressure a little bit. So none of them are perfect. There's no slam dunk answer, but there are a lot of good medications on the market, and we can try several ones. And if you come to a doctor who's savvy about this, we can argue with your health insurance company to get the ones that are safest for you covered. If medications don't work, we could also inject Botox into the bladder muscle itself to calm it down. We can also implant a pacemaker. Just like you can put a pacemaker in a heart that's not functioning well, we can put a pacemaker for the pelvic floor that can help with overactive bladder or with bladders that don't empty. That's called InterStim, or sacral neuromodulation. There's even a therapy we can do where we put a needle in through your ankle, like an acupuncture needle, and connect it to stimulation and do 30 minutes of stimulation every week for a 12-week period and improve your symptoms by 60 to 70%. So there are a lot of options. So if you ask somebody and they say, oh yeah, you are getting older, you know, there's not much you can do about that, you say, I want you to send me to somebody who can help. And for a woman, that could be a urologist or a urogynecologist. And for a man, that should be a urologist. For men, I'm just going to briefly touch on the options. There are medications that target the shrinking, the prostate that's swelling. There's also a special catheter that sits over the penis and catches the urine. There's also a clamp that sits at the end of the penis and catches the urine. There's a surgery to decrease some of that extra swelling around the prostate, and there's even a pump that you can put inside the urethra that you pump up with air to stop urine leakage, and then when you want to go to the bathroom, you deflate through the scrotum, and then it empties and allows the bladder to empty. I don't take care of men, so I don't know a lot about these therapies, so I'm going to give you that caveat. But urologists can help you with all of those therapies if you know a man who has these issues and has tried the simple modifications and still needs more. I'm now going to transition to bowel control. 15 million US women over the age of 40 experience accidental bowel leakage, ABL. That's 1 in 5 women have it occasionally, and 1 in 12 women have it on a monthly or more basis. Less than 30% talk to their healthcare provider, and this is actually my big focus in my research, is about identifying why it is that we all think that everybody's got urine leakage, but nobody thinks anybody else has bowel leakage. The bowel continence mechanism is a little bit more complicated. Now remember, we are talking about if this is one of those same pictures where the pubic bone's here, the bladder's here, the vagina's here, and the rectum's right here, and the anus is right here. Just like with the bladder, there are muscles and nerves in the rectum and anus that hold stool, let you know when the rectum is full, and signal when to release stool. And there are pelvic floor nerves and muscles that work together to help with bowel and gas control. However, with the bladder, it's a little bit more simple. With the bladder, remember, the bladder stores urine that's made by the kidneys, and as it stretches, it sends a message to the brain and says, I'm full. Now, the rectum can't just send a message saying I'm full, because the rectum can be full with lots of things. The bladder only ever has urine in it. But the rectum could have gas, it could have formed stool, it could have loose stool. And so you need a way for your rectum to communicate to your brain what's in your rectum and how much time do you have. And so there's a complicated mechanism. When stool arrives in the rectum, there are two little trap doors, and that's called the internal sphincter and the external sphincter. So when anything comes into the rectum, the internal sphincter opens and the external sphincter closes to allow some of the contents of the rectum to stay right in this anal canal, which is really less than 2 inches long. But those little stars represent the special nerves that have the ability to distinguish solid, liquid, or gas and send that message up to our brain. The anal canal sends the message to the brain about what's in the rectum, and the brain decides what to do. Oh, that's just gas, there's nobody around, I'm just gonna let it out. Or, ooh, I gotta go right now, that can't wait. And in addition to those two muscles, there's also this muscle called the puborectalis, which goes from the pubic bone and wraps down around the rectum and helps keep this at a nice L shape. You can imagine that if this muscle got injured from radiation or surgery for prostate disease or from a traumatic childbirth, then the line, instead of being an L shape, would end up being more of a straight line, and then it would be even easier to lose stool or gas. Bowel control problems can include accidental loss of gas or bowel contents, chronic constipation, or diarrhea. And if you have problems with chronic constipation or diarrhea, it's important to let your primary care doctor know, because remember that changes in stool can be significant and can suggest something else going on. But they also just happen with what we eat and drink and with our level of physical activity. So they shouldn't be cause for alarm, but they should be cause to discuss it with your provider. There are 4 pearls for self-management of bowel control. And the last 2 are similar to the bladder ones, but the first 2 are a little bit different. 1 is modifying stool consistency. 2 is tracking your symptoms. 3 is pelvic floor muscle exercises, and 4 is weight management. Modifying your stool consistency. We've talked a lot about fiber already today. For both constipation and diarrhea, fiber helps. If your stools are too loose, fiber bulks them up. If your stools are hard little pellets, fiber pulls water into them. The secret is whether or not you use water with your fiber. That's how you control what happens with your stools. You need to drink plenty of fluids as you fiber supplement. If you have accidental bowel leakage, you should avoid spicy food, caffeine, and anything else you identify as triggers. Some people identify wheat as a trigger for loose stools, or milk products, or Olestra, or chocolate. If you identify foods that are triggers for you, avoid them. If you suffer with constipation, avoid starches that can bind you up, like white rice, bread, and pasta. The second step is tracking your symptoms. I can't tell you how often I talk to my patients about stool type. Okay, this is on my new patient questionnaire. Type 1 is little rabbit pellets, hard to pass, straining, that's really constipated. Type 7 is entirely liquid, that's you ate something bad in Mexico and it's just rushing out, right? And then there's everything in between. The easiest type of stools to hold on to are type 3 or 4. That makes sense, right? If you imagine trying to hold liquid in your cupped hands, it's a lot harder than trying to hold something that's well formed. And similarly, tiny little pellets can also slip out pretty easily. So a big part of bowel leakage control has to do with optimizing your stool consistency to make it a type 3 or a 4 that's easy to hold on to. You can keep diaries of what you eat and drink and how that impacts your stool consistency to figure out what it is you need to do to get your stools to where they need to be. Pelvic floor muscle exercises we already talked about. It's the same. Remember, those muscles go from the front to the back. So it's not separate muscles, it's all the same muscles. Doing your pelvic floor muscle exercises will help with both. The other thing you want to try to pay attention to if you have bowel leakage is see if you can identify when things are coming to your rectum. It's not something we ever really pay attention to, but if you can start to identify that, if you can become mindful of that, then you can tighten that external trap door, which over time might get weak, so that the internal door relaxes, but the external door doesn't contract, and then you can have a leak. But if you can get a sense of, oh, stuff is coming on now, and you tighten, you can stop that external trap door. Lastly, weight management. Again, you got to diet and exercise in order to change what your body weight is. I also want you guys to know about butterfly body liners. Anybody who has bowel leaks, these are helpful to know about. These are, lots of people with bowel leaks tuck a little bit of toilet paper inside just at the opening of the rectum so that they can catch those little leaks before they get to the bathroom. And this is a paper product that actually adheres to the inside of your bottom so that it puts the solution where the problem is and it doesn't migrate, and it's not ever going to end up coming out of your bottom of your pant leg because it just stays right there. So this is a really nice product. It's the only thing, you know, there's an entire aisle for urine stuff, but there's really not very much for bowel stuff. This is available at Walmart and Target, but it's a small company, so you can't get it in Walgreens. I think it's going to be in CVS soon, but right now for sure you can get it at Walmart and Target if you do have bowel leaks. If these solutions don't work, you should talk to your primary care provider, who again may refer you to pelvic floor physical therapy, or a gastroenterologist if you're having changes with stool, a colorectal surgeon if it seems like you might have hemorrhoids, or a urogynecologist, somebody like me. And if your primary care doctor says, oh, you know, there's not much you can do about that, say, no, I actually don't think that's true. I think there are things you can do about that, and ask for a referral. Because the truth is that, you know, doctors are people just like everyone else, and we don't all know all of we can't stay up to date on everything under the sun. So if you feel like you get up the nerve to ask your doctor and your doctor doesn't have the answer, just ask for a referral. The additional treatments for accidental bowel leakage will first tell you to fiber supplement. We'll talk about skin care. If you have bowel leaks, then you probably need to be doing some skin care, just like you take care of a baby's bottom. You know, with our babies, we're so careful. We use wipes, we pat, we never scrape. We put Desitin there to keep everything from getting a rash. And with us, we don't tend to dote on our skin the same way, but it's the same sensitive skin. So if you have problems with bowel leaks, skin care is important. There's also an office procedure we can do where we put some bulking material right in that anal canal, that last 1.5 inches between the rectum and where you have your bowel movements from. And we can bulk that up just like the bulking for the garden hose. We can do the same bulking for the rectum. We can also do that pacemaker. You know how I told you about the pacemaker for the bladder? If your bladder doesn't empty or if it empties too much, that same therapy works for the bowels. If there's a focal injury to the anal sphincter, that can be fixed surgically, but that's almost never the answer for bowel leakage in an older adult, because it's almost never just a problem with your sphincter. So if somebody tells you that that's the solution, you want to ask for a second opinion, because probably a better solution is one that targets more things in the diagram. And last of all, we're doing a study right now testing a pessary for bowel leakage. It's only been tested at a few sites, and we got selected as one of the 12 sites across the country that are going to be testing it in the larger study. So if you do have bowel leakage and you're interested, keep an eye out. We'll be announcing recruitment for that study next month. I'm going to close with a little bit on pelvic organ prolapse. Pelvic organ prolapse is relaxation of the walls of the pelvic floor, and about half of women between the ages of 50 and 80 have some form of prolapse. So who's at risk? The same people who are at risk for all these other things: being postmenopausal, giving birth one or more times, being overweight, smoking cigarettes, being constipated, having chronic lung disease. So what is prolapse? The pelvic floor muscles and ligaments are stretched or become too weak to hold the organs in their correct position in the pelvis. As it progresses, women can feel bulging tissue protruding through the opening of the vagina. The most common is dropping of the front wall between the vagina and the bladder, and that's called a cystocele. The second most common is dropping of the back wall, which allows the rectum to pooch into the vagina. And the least common is dropping of the uterus, or if you've had a hysterectomy, dropping of the vaginal cuff, the top of the vagina. Symptoms include pressure and heaviness, bulging, feeling a lump or a lump that comes out beyond the opening of the vagina, difficulty starting your urine stream or having a slower urine stream, problems with emptying your bowels, chronic straining or needing to push inside. And the treatments for prolapse depend on how much it bothers you. Prolapse is not life-threatening, but if it's bothersome, treatments can help improve your quality of life. I feel like probably 10% of women who come to see me for prolapse came because their daughter saw the bulge and said, oh my God, you've got to get in, you've got to see somebody about that. And the patient says, yeah, I've had it for 15 years, it really doesn't bother me. Okay, all I can do is make that patient worse. Okay, but some people have a bulge that's just the size of an egg, and they're extremely bothered. Some people have a bulge the size of a grapefruit and it doesn't faze them. So it's all about what the symptoms are for you. If it bothers you, there are things we can do. If it doesn't, you don't need to do anything about it. The conservative approach is to watch and see how things go, make some dietary changes so that you're not so constipated, do pelvic floor muscle exercises. You can wear a pessary, which you saw a picture of earlier, to support the walls of the bladder and the vagina. You can also have a surgery, but every woman's situation is different and there's no single operation that's right for every patient. The specific type of surgery that's right for you depends on your body, your overall health and other health problems, what other surgeries you've had, whether or not you're sexually active and plan to be in the future, and the experience and training of the surgeon that you go to see. The goals of surgery are to restore normal anatomy, reduce the bulge, and improve your quality of life. And the success or failure of someone else's operation should never be the deciding factor for you. You and your doctor together can make a decision about what's best for you, and it's never wrong to get a second opinion if you feel like this is a big decision. I want to close with a couple points. I don't want you to be embarrassed because you're not alone. Bowel and bladder control problems and prolapse can be upsetting and embarrassing. They are very common, but they are not a normal part of aging, and you don't have to live with them. You're not the only one who has them, and if these pearls that we talked about today for self-management are not enough, talk to your doctor. You don't need to live with these things. If they don't bother you, for sure, you can live with them and you don't need to be subjected to risky treatments. But if they bother you, we actually have a lot of treatments available. I work at UW Hospital in the Women's Pelvic Wellness Clinic there are a total of 3 of us who do pelvic floor care, Dr. Giles, Dr. McCachran, and myself. And we have twice a month a multidisciplinary clinic where we actually have pelvic floor physical therapists in our same space, and we can also have colorectal surgeons and nutritionists come if we think that you need those things as well. We're also really lucky in Madison to have 3 great pelvic floor physical therapy groups. There are groups at Meriter, UW, and a private group in town called Capital PT. And I've had the pleasure of working with these teams of women for the last 1.5 years that I've been here, and they're really phenomenal. So, and even if you live elsewhere other than Madison, there's a website you can go to, which is apta.org. American Physical Therapy Association, I think. And you can search by your zip code and by the specialty of women's health to find pelvic floor physical therapy near you. But we're lucky in Madison. I've actually never worked in a city that has so many pelvic floor physical therapists. I want to close with a quote by a woman who participated in one of my focus groups for my research. And what she said was, "Why do we not talk about this? People don't talk about sex or dying, and those are the 2 things almost every human does." You know what I mean? I think it would be a nice thing to see, talk to your doctor about incontinence, bladder and bowel or something. A big poster in every doctor's office. Just bring it out of the closet. I didn't even know I had mine in the closet until I'm obviously so upset about it, and I must have. So it's hard to talk about these things. Not for me. I mean, this is all I talk about every day, clearly. I'm comfortable. But I understand this can be a sensitive issue to talk about. And if you do bring it up with a doctor and you don't feel like you get the answers you need, push. Because not all doctors know what to do, but there are doctors who can help. Thank you very much for listening. I welcome your questions.